Thank you, Dr. Neera Gupta, and I welcome you all and thank you for joining it today. And the main discussion mostly about unresectable, which are not amenable to surgery. So I welcome, we have eminent speakers today. We have eminent faculty today. I don't think they need introduction. And from these people, we have been learning how to treat head and neck cancers. They have been part of a multiple clinical trials. They have always showed us a way how to go about it. I think Dr. Kumar Prabhas, sir, everybody knows him. He does not need introduction. Welcome, sir. Dr. Sarbani Ghosh, ma'am. She also does not need introduction. Welcome, ma'am. And Dr. TP Sahu. Welcome, sir. They have been part of multiple clinical trials. And we know although multiple clinical trials and the McKenzie meta-analysis did demonstrate a survival benefit from chemoradiotherapy. Everybody knows that. And what I believe that still the optimal concurrent regimen has not been defined. And in McKenzie meta-analysis, it did found a greater benefit for platinum-based chemotherapy as compared with other chemotherapy regimens. Platinum, cisplatin became a winner. And we know this cisplatin efficacy of platinum is dose dependent, and higher the total doses, more the efficacy. And I think regardless of the schedule used, that is a standard now. We know that we'll be discussing that in a while. And if somebody is platinum ineligible, what I consider cetuximab to be an acceptable option, yet less effective. And it is an alternative in patients with good performance status who are not candidate for cisplatin or carboplatin, patients on dialysis with hearing impairment and with neuropathy at baseline. Preferred cisplatin dosing, weekly, 3 weekly. I think phase 2, phase 3 clinical trial, JCOG 1008 has shown us a way. I think we have a Tata data, and which had compared 30 mg weekly versus 100 mg. And why 30 mg? I think we'll be debating that today. And if somebody is cisplatin ineligible, how to go about that? I think carboplatin is more acutely myelosuppressive than cisplatin, but it causes less neurotoxicity, nephrotoxicity, and nausea and vomiting. Cetuximab and radiation therapy, we know a lot of toxicity, lot of mucositis, treatment interruptions, very challenging to treat such patients whom we give cetuximab plus radiation concurrent. And there are other drugs apart from cetuximab which have been tried. Actually, these are the drugs like panitumumab has been tried, erlotinib has been tried. And now we have our own data, I think TMH data, nivolumab plus chemoradiotherapy, which actually has shown a survival benefit for such patients. Because we know these are the patients who relapse very quickly. I think 3-year DFS of 40–50%, that's very less. And I think there is an unmet need for combining radiation and chemo and to get better drugs, to get better anti-EGFR, better chemotherapy, so we can prolong the survival. And we know coming during last couple of decades, the radiation has really, has changed how we deliver it to our patients. IMRT, IGRT, not only that, not only IGRT, IMRT, but the radiation therapy planning techniques have changed. Initial assessment have changed. We know radiation therapy schedule, the March meta-analysis, we know, everybody knows, we'll be talking about that. We'll be talking about duration of treatment, radiation therapy delivery time, and I think adaptive radiation as well. And role of surgery after CTRT, definitely. So I think we should start our proceedings, and first talk, I think I invite Dr. TP Sahu, and he will be talking about what is the role of medical oncologist. He will be talking about from the medical oncologist perspective in the treatment of locally advanced head and neck cancer. Dr. Sahu, please share your slides, and I invite you to please start your presentation.